Hello everyone, my name is Osama Khamaj, and today I'm going to discuss the lecture Hemodynamics for the ninth physiology lecture. So, today we're going to discuss three important topics, and they are compliance of arteries and veins, mean arterial pressure, pulse pressure, and venous pressure, and starting forces. So, we're going to start with the compliance of arteries and veins. Now, we need to understand these two words because we're going to use them a lot here. Elasticity. Elasticity is the ability to recoil when stretched due to high pressure being applied when we talk about blood vessels. Compliance and distensibility is the ability to stretch when higher pressure is applied. So the difference between elasticity and compliance is when you stretch an elastic object, it recoils. When you stretch a compliant object, it stays stretched. That's the difference. So you can see the difference here. Arteries are more elastic, so there's more recoil opposing force. So you'll have less capacity to hold blood. While veins are the opposite. They're more compliant. They're 8 times more compliant than arteries. They can hold more blood when stretched because there is no elastic opposing force, unlike arteries. And this analogy explains this very well. Artery is like an elastic band. If you stretch it, there's an opposing recoil force, so it won't stay stretched. But veins, when you stretch the veins are like a balloon. When you stretch them, they stay stretched. They don't recoil, unlike elastic bands. Vascular capacitance is how much a blood vessel can stretch to hold extra blood for a given increase in pressure. So if you increase the pressure by a certain amount, the extent to where the blood vessel can stretch to hold this extra blood is the vascular capacitance. And we can see due to because veins are more compliant than arteries, they're 24 times their capacitance is 24 times that of arteries. And like I said, depends on the distensibility of the blood vessel, and veins are more distensible than arteries. And this graph shows this relationship. If you increase the volume by a certain amount, pressure doesn't increase as much. Or when you increase pressure, you can hold more blood as a vessel. But arteries, if you increase the pressure, it can't hold as much blood. You see, the volume doesn't increase much. But in veins, the volume increases by a lot, so it can hold more blood when you increase the pressure. This is why veins act as a blood reservoir. Uh, Blood can be stored in veins, basically, unlike arteries. And why is this so beneficial? Why do you want to store blood in our veins? When sympathetic activity increases, the body requires a greater cardiac output. The body needs the heart to pump more blood. So how do we get that? The sympathetic activity from the nerves causes the venous smooth muscle to contract. It causes a decrease in compliance. They aren't as compliant as before. So this pushes the venous blood into the right atrium, into the heart, which will increase the venous return. When you increase the venous return, there will be more blood in the heart, which will increase preload, increase increase the stretch of the heart wall, which will increase the cardiac output because the heart will now pump more blood since there's more blood in the heart that returns from the veins. Aorta, on the other hand, when the ventricle contracts during systole, it pushes blood into the aorta. This stretches the aorta, and like we said, aorta is elastic. So when you stretch it, it will recoil back. This recoil pushes blood further into the vessels, into the large arteries, which will give it a push into the arteries, arterioles, and capillaries, so it can reach the tissues. Now, the second topic, pulse pressure. Okay? Pulse pressure is the difference between systolic and diastolic pressure. Systolic is normally 120 and diastolic is normally 80. So the difference is about 40 millimeters of mercury. And this equation, you can see the relationship. systolic pressure minus diastolic pressure is equal to pulse pressure. Now the factors that affect pulse pressure are stroke volume output. If you increase the stroke volume, there will be higher pulse pressure, and you can see here pulse pressure and stroke volume are directly proportional. Arterial compliance, when you increase arterial compliance, pulse pressure decreases, and vice versa. When you decrease arterial compliance, pulse pressure increases. So pulse pressure and arterial compliance are inversely proportional. Yeah, you can think of pulse pressure as moving waves of pressure that push the blood forward. The pulse pressure is basically the difference between, like I said, systolic and diastolic pressure. So pulse pressure is the difference. So it's kind of a push that pushes the blood further into systemic circulation. And there's a relationship between the velocity of pulse pressure and the compliance of the artery, like we talked about before. The greater the compliance of a vessel, the slower the velocity of pulse pressure. As you can see, aorta is the most compliant artery, so it has lower velocity. And as you move on into systemic circulation, compliance decreases, so velocity increases. As you can see, these values. Now, let's talk about the normal graph, the normal pressure graph first. The top, the highest point is the systolic pressure, and the lowest point is the diastolic pressure. The difference between them is what we call the pulse pressure. So now we're going to talk about how different conditions affect the pulse pressure. With arteriosclerosis, we have a stiff aorta. Stiff aorta means the aorta is less compliant. It has less recoil force. And you can see in this kind of graph, the systolic pressure is higher and the diastolic pressure is about normal too, but the difference between them is higher, which leads to a greater pulse pressure. Like we said, the difference between systolic and diastolic is the pulse pressure, this line right here. Since it's longer, there's greater pulse pressure. Okay, now with aortic stenosis is basically the narrowing of the aortic valve. Less blood will flow through the valve during systole. Okay, this is because there's a narrowing of the aortic valve. This will cause lower systolic pressure, leading to a lower pulse pressure. As you can see, it's slightly lower than normal systolic pressure. So it's closer to diastolic pressure, which will decrease pulse pressure, the difference between the 2 points. Okay? Now with patent ductus arteriosus, it causes greater systolic pressure, as you can see, but it also causes lower diastolic pressure. If you notice the difference, it's lower than normal. So there's a huge difference between systolic and diastolic pressure, which will cause greater pulse pressure. With aortic regurgitation, there will be backflow from the aorta into the ventricle after systole. This will cause blood to move back into the left ventricle and will cause lower aortic diastolic pressure. Now, the left ventricle has more blood to pump into the aorta, so it will cause greater systolic pressure. Now, greater systolic pressure, if you can see here, there's greater systolic pressure than normal and lower diastolic pressure than normal. This will cause a huge difference between the two values, which will cause a high pulse pressure, greater pulse pressure than normal. These two graphs are the normal pressures, so these are the references. Now let's talk about mean arterial pressure. Mean arterial pressure is directly proportional to both cardiac output and variable resistance. The more the heart pumps blood into the arteries, the more they stretch. And the more the resistance from arterioles, the more blood stays in the arteries, so they will stretch even more because they're elastic, remember? So, increase in cardiac output, increase in mean arterial pressure, increase in peripheral resistance, increases mean arterial pressure. Okay, you can see they stretch more. Whatever makes the elastic arteries stretch more increases pressure. So, resistance, when you constrict the arterioles, when you constrict them, there will be more blood left here because there's less place for the blood to flow. So blood will accumulate here, which will cause higher mean arterial pressure. And like we said, the main factor affecting peripheral resistance is the vasoconstriction and vasodilation of arterioles. Now let's talk about central venous pressure. Central venous pressure is the pressure in the right atrium, the blood pressure in the right atrium. It's normally around 0 millimeters of mercury. And the four main factors that affect the central atrial pressure, which is also called the central venous pressure. Increased blood volume. When you increase the blood volume, more blood will be in the right atrium, which will increase the pressure. When you increase venous tone, like we said in the sympathetic response, there will be more venous return. So there will be more blood in the atria, which will cause greater pressure. And when you dilate the arterioles, there will be more blood flowing in the venous system, which will increase venous return again, which will increase the pressure in the right atrium. And decreased cardiac function. If you have decreased cardiac function, then the essential atrial pressure will also be affected. But what, like we said here, in a standing person, how is the blood not accumulating in the foot due to gravity? It should accumulate in the foot, especially since there's no pressure pushing it. The heart pumps blood into arteries, but there's no structure that pumps blood into the veins. So how does it go back to the heart, like into the inferior vena cava, and go back to the heart and not stay in the legs or in the feet? Unidirectional valves. Valves, they prevent backflow of blood down into the veins. So blood only goes up. The valves prevent them from going down due to gravity. And there's a condition called varicose veins. It's when they're damaged or weak valves. Blood flows down due to gravity. Like that's the normal physiology, but we should have valves that prevent this. Okay, since the valves are damaged or weak, blood will build up in the lower superficial veins, which will be visible because the veins will stretch as they're filled with blood. Now let's talk about stalling forces. There are four main forces that we have to consider. The first force is capillary hydrostatic pressure. It's the pressure exerted by the fluid inside the capillaries. This pressure forces fluid out of the capillary and into the interstitial fluid. This is the force right here. The more fluid you have here, the more fluid will wanna leave the capillaries. So this is for filtration. Filtration is the movement out of capillaries. So it promotes filtration. Plasma colloid osmotic pressure or oncotic pressure is the osmotic force exerted by the impermeable proteins in plasma that pulls fluid or water into the capillaries. This is osmosis. Since the proteins are impermeable to the membrane, they want the blood from the interstitial fluid, the fluid, not the blood, the fluid from the interstitial fluid to go back to the capillaries. Okay, that's what the force is. And interstitial fluid pressure is opposite to capillary hydrostatic pressure. Is the pressure exerted by the fluid in the interstitial space, forcing the fluid out of the interstitial space and into capillaries. So when you have more fluid in the interstitial space, it wants to go back to the capillaries. Okay, and it's opposite to capillary hydrostatic pressure. Now, interstitial fluid colloid osmotic pressure is the fluid exerted by the proteins in the interstitial fluid. It pulls fluid or water into the interstitial space from the capillaries. So it's almost opposite to plasma colloid osmotic pressure, since plasma osmotic pressure wants to pull blood into the capillaries, while interstitial fluid pressure wants to pull blood out of the capillaries. They're opposite. And these two in green, they're for filtration. Filtration is movement out of capillaries. And these two in red, they're for reabsorption. Reabsorption from interstitial fluid into capillaries. And this is the equation that allows you to figure out whether there's filtration or reabsorption. But it's called the net filtration pressure. the green ones, remember the green ones, PC, which is capillary hydrostatic pressure, and oncotic pressure of interstitial fluid. You add them because they're full filtration, and you subtract the interstitial fluid pressure minus this is the oncotic pressure in capillaries, and this is the interstitial fluid pressure. You subtract them and you add these. If you get a positive value, then there is filtration. If you get a negative value, there is reabsorption. And the role of lymphatic vessels, if there is excess fluid or proteins that wants to pull fluid into the interstitium, then lymphatic vessels, they absorb these fluids and these proteins, so the tissue stays dry and there's low interstitial oncotic pressure, so there's less filtration. Why do we want less filtration? Because lots of filtration will cause edema. If you can see here, edema is the buildup of fluid in the interstitial space or tissues. When the lymphatic vessels fail for whatever reason to drain the excess fluid and proteins out of the interstitial space, this result in edema. If you see here, there's buildup of fluid in the tissues of the patient, particularly in the lower limbs. They're mostly in the lower limbs. And thank you guys. I hope this helped. And there are some equations I didn't include, but check them out. I think after this lecture, you'll be able to understand it better. Thank you.